directed towards the pelvis.
Can I have somebody from the audiovisual team? Professor Ratri has raised a very pertinent question, gallstones. So I would like to know from the experts, what would be your idea if patient has gallstones and patient is undergoing hernia? With the advancement of ET, things become a little bit easier.
Professor Iqbal sir?
Yes, Professor Ratri.
Thank you so much. We'll be just revising our anatomy here. This looks to be a direct defect, and this is the, you see, midline. This is the midline here.
Yes.
This is the, you see, median umbilical ligament, we presume remnant of urethra. This is the medial umbilical ligament, and we come here, this is the inferior epigastric vessel here. So a hernia which is medial to the inferior epigastric vessel is a direct inguinal hernia. So these are the testicular vessels here, and this is the vas going. Maybe possibly because of previous surgery, there is some sort of distortion here in the internal ring, but it's okay. And we will be starting our peritoneal incision almost 2 centimeters anterior superior to the iliac spine, anterior superior iliac spine, and then we will proceed. Sir, I am thankful that Dr. Fuller sir agrees that in the beginning we were, you see, trained in TEP. So I started doing TEP from 97 onward, and till 2000 I was not knowing that TEP is better or TAP. After 2000 I started learning TAPP, and now I feel that TAPP, as Professor Sarfraz has put in the right words, it may be the last laugh for the surgeons.
Professor Ratri kindly shows the vascular anatomy there. It's so beautiful.
It is
I think
so
the postgraduates would love to see
this. This is the, you see, our iliac vein, this is the artery. We can see so much of, you see, it's such a clear thing. But it is a very tortuous artery.
Yeah.
It's not that straight we see normally. Right? Can I request anesthetist to please just put a head low patient. And this is the, you see, vein as we know, and this artery is going like this. Maybe just a few bit of anomaly here, but these are the testicular vessels as we know, and this is the internal ring. So this is the angle of doom here, and now we'll proceed with the, I think, incision. Incision should be almost 2 centimeter anterior superior to iliac spine. We'll be just giving a horizontal incision. Normally we can use you see scissors, but you see, as I have given incision, the CO2 pushes in and the peritoneum is lifted, so this helps us in our dissection. So we will be giving a horizontal incision to the peritoneum at least 4 to 6 centimeter up to medial umbilical ligament.
And we have to inform the audience that Professor Ratri is well versed with the use of scissors, but just for the demonstration purposes, he is using a harmonic. We believe that the right instrument should be used at the right place.
Right.
Harmonic is not a cheap instrument, but we want to demonstrate all the products that the companies have put forward that way. I welcome Professor Nisar and Professor Chalku who have joined us. Professor Nisar is an oncosurgeon who was with us, and one of my seniors. Can we have claps for them, please?
And as we go medially, we have to just take care that we take care of the inferior epigastric vessels, and we all know that peritoneum is again single cell layer, and the fat belongs to the anterior abdominal wall. We have to just, you see,
Audio team, audiovisual team. Can we have GOT1 on now? So, I'm sorry, Professor Ratri, you were saying something very important.
So single, since peritoneal, it's a pre-peritoneal repair, so we have to be, you see, along the peritoneum all the time. And since it's a single cell layer thick, so we have to make it sure that we don't create buttonholes during our dissection. And we don't have to go into the plane which is, you see, pre-facial. So I'm just trying to make this lateral space first.
Excellent dissection, boss. Keep it up. This is the most crucial step in the hernia surgery, because if you deviate from the path that you have to follow, like you can see there is this cobweb appearance is there, that is the surgeon's friend. I keep on repeating, this cobweb you are in a good plane. You will have minimal bleeding, but if you deviate from it, you're bound to have a lot of bleeding during the procedure.
We have one question pending, that how to deal with gallstones along with hernia.
Yes, we wanted...
Sir.
Professor Agies from Skims Medical College wants to
Joined us.
Yeah.
Oh, of course. My colleague, my classmate, Professor Agies, he is heading the Department of Minimal Access and General Surgery in Skims Medical College, and he has just returned from the Holy Pilgrimage, and I think that's why I could not recognize him, because we have to shave the head there. Now your mic is not working, boss. Just a minute, they will correct you. Yes, please.
Thank you, Professor Inguinal, for your kind words. It's indeed a pleasure to be here always and seeing my dynamic friend always performing something new, and he always focuses on the particular topic. It's like he has chosen hernia this time. So last time we had also some other on morbid obesity. So it's always a pleasure, sir. So, but I want to answer that question, that if the patient has a concomitant gallstone and the hernia at the same time, as you can culture in about 60% of the cases, bile is infected. So as far as you should first try to avoid it, but do first lab poly. If there is no spillage of the bile, then you can try. TAPP is the better option because you are not violating the bacterial cavity, but you can also do TAPP even if you are using the mesh if there is no contamination. But if there is contamination, always please avoid the TAPP. So you can go for TAPP, there is no issue. This is my take on that.
What would be the idea of the experts? Do we have the mic on the right section? Sir, please identify yourself and so that we get to come to one to be.
I am Dr. from GMC, so I would like to address.
Welcome, sir.
I would like to address the start with TEP, TAPP. I will have some slightly different opinion. Right. So one is that there is obviously TEP, TAPP. They are almost comparable, and some people say TAP better, some people say TEP better, but it is vis-a-vis only one clear.
Just a minute, sir. We'll be going to GOT1.
Sure.
Just a minute. GOT1. Audiovisual. Can we have GOT1 on? Kindly identify yourself.
हर्निया में कोई भी जल्दी 25% of abdominal cavity नहीं होगा. These are the switching ways which will look at frontal wall effect with condition of orbital and colon. This is a short video of this.
Okay, so first of all, thank you everybody for inviting us. Thank you for engaging with the Hernia Society of India and to all the organizing team. It's a great pleasure to be with you all and a great honor as well. So the job that I've been given today is to operate on this 70-year-old lady. She about a year back in a district hospital, she underwent a laparoscopic gallbladder surgery. And then from the lateral pole, she had a bleeding. And she was explored for the bleeding and the hemostasis was secured. Now from that same lateral pole, she then developed an incisional hernia.
Professor Sunil, come to front, please.
Incisional hernia was repaired using an onlay mesh. So if I can show you, you can see that there is a, I'll show you the entire abdomen, that is the head end of the patient. And this is the CT sternum, and you can see it's a very small abdomen, right? So it's a 70-year-old lady, just about, I think, 4 feet 10 inches in height, and it is a small abdomen. This is the CT sternum. I have marked out the costal margins on both the sides, and we have the roller box or the plane below the right hand flank. So it's slightly just by 20 degrees. Raise the right side up, okay? Now, we have marked the bony margins. You can see this is the anterior superior iliac spine here, right? That is the anterior superior iliac spine. And this is the pubic bone. This is the pubic bone. This is the midline. This should be the linea alba because the patient is in a little wacky position, so it's coming here. This side, apparently this looks like to be the mid-clavicular line. And this is the scar area where there is a hernia. You can see that there is the incisional hernia. Now this counts as a L2 and the W1 hernia because on CT the defect size is 4 cm by almost 3.5 cm. You can see how much is the defect actually. Now what are the challenges with this hernia? One is, first challenge is that this is a small abdomen, right? So there is a limited working space. Second is, it's a lateral hernia, it's a boundary wall hernia. So, on one side, you can see that there is the pubic bone, and on the other side, there is the costal margin. So, it is just between the costal margin and the pubic bone, and this space is a very limited space. Can you see that? Now, once you have a boundary wall hernia, these are more challenging. If they are near any of the, whether the pubic bone or they are near the iliac spine or whether they are near the costal margin. And we have a very narrow space here. Can anybody show the CT scan?
Dr. Sumit, we have chosen this case especially for you so that we give you some trouble and you will show us all the expertise that you have. I take this opportunity of welcoming my colleagues from Government Medical College, Jammu, Professor Noor and Professor Satish. It's wonderful to have you here. Can we have some claps for them? I think all my postgraduates are slightly drowsy because they were here till 12 o'clock. Most probably. Thank you, sir. Thank you for being in time.
Professor Iqbal, sir?
Sure, sir. Please go ahead. Sir, please go ahead. Are you getting me, sir? Audio visual, I think we are not getting the audio there.
Professor Iqbal, sir? Am I audible?
Sir, you were saying something. I'm sorry. We had
I know it's very interesting discussion. I mean, is it audible to in the
I think the GOT one is not. They are not audible.
Is it audible? We can ask some question to him.
GOT one or GOT two?
The GO2 one. Yeah.
Sumit is in GOT one. Professor Atri is in GOT two.
So GOT1, can we ask a question?
Yeah, sure.
Dr. Sumit? I think it's not.
You can ask us. We pass it.
Yeah, I mean, how does he compare right-sided ETEP TAR versus TAM with IPOM? How does he compare that?
Dr. Sumit, did you get the question?
So actually the audio is not very clear.
Okay. Could we have Dr. Safraz to answer this question for the time being?
Sorry, repeat the question, please. I mean, how do you compare in this patient doing right-sided ETEP TAR versus IPOM TAR?
So I think we are now more or less been on the ETAP journey for 6, 7 years. All of us, many of us are there. So we've realized that ETAP is a technically demanding surgery. We are cutting the PRS from one side to other side to enter that space building. Space creation is pretty good with ETAP, there is no doubt. You can put that in big match. The question that now we are asking after planning that journey is, do we need that kind of space? A, do we need to cut somebody's PRS? Do we need to have a mesh which is 20 by 20 for a hole which is 2 centimeters?
Can I just interrupt one thing?
Yeah.
So in this patient you don't need to cut PRS because you can do right-sided. So you don't need to, because if the defect is more than 6 centimeters from the lesbian iris, you don't have to cross over. You can do the right-sided retrograde. All we need to do is TAR. And I think doing a TAR in this patient is going to be handy in getting a tension-free closure. So that will be a component separation on that side, which will help because this is the bony area and will be very tough tissue, and its defect may look very small but it will be very tough. So I think TAR will help us in closing the defect. We'll not do the crossing midline because if it is beyond 6 centimeters, we can do the space. And I think working in roof and letting the peritoneum fall with it is easier because you get a natural pneumodissection. Peritoneum falls. I mean, these cases are, I think, very easy to do by ETAP technique. The moment you get your correct TAR plane, most of the things become automatic by a pneumoperitoneum. So a lot of things which we are doing even in TAPP, which is done easily by pneumodissection if we get to the right plane. So I don't know, I feel that right-sided ETAP TAR without cross the midline would have been easier. We do it very frequently and we find it easier than doing IPOM and TAR. I mean, that's my take. But I agree that you need to do a lot of cases. There's a long learning curve for to get into right ETAP.
So I think I agree with your concept that if it is 6 centimeters away from the midline.
Just a minute, Dr. Safraz, just a minute. Audiovisual number one, you can see the image from inside. It looks a very nice hernia. Number two, can we shift to Professor Atri because he's at a crucial phase. Then we'll just listen to Professor Safraz answering the question.
ठीक है, okay. 10 minutes देंगे.
Professor Iqbal sir.
अभी रुको.
While we are with Professor Atri, we must congratulate him for his fantastic research. It's a very slow, subtle movements, very soft hands. We were all discussing here between ourselves that he's got fantastic hand movements. He's a world-class operator.
Thank you.
That's good, sir. I feel proud to be part of the department that has nurtured him for the last 20 years.
Thank you so much,
I
sir.
must be very proud. I congratulate you all for all this excellent work that we're seeing here.
Thank you, Chairman, for nurturing me.
Professor Atri, are you getting me?
Oh yes, I am getting you. So till now we have just dissected out this flap, peritoneal flap, and we have we encountered few adhesions here, and we have just made this peritoneal limb as a horizontal limb. Now this is the lateral spermatic vessels. This is the vas going medially, and this is the peritoneum which has been refracted down. and there were you see very dense adhesions along the past, but we have been able to just sail through them. And the medial, since he had a direct hernia, so we have dissected out the pseudo sac. It has gone back into this, and just we will be completing the medial dissection. Thank you so much, sir, for nurturing me, but your many things are pending.
Keep on.
Since this is a facial surgery, planar surgery, we have to just go 2 centimeters below the, this is the pubic ramus, right? This is the Cooper's ligament.
Yes, we are
Right,
getting
sir?
the lighthouse
So
sign from you, sir.
this is the lighthouse. My cameraman, show the lighthouse, please. So this is the right-sided Cooper's ligament. This is the symphysis pubis, and we just know, since it's a recurrent hernia, otherwise also we need to go at least 2 centimeters across the opposite side, even if there is no hernia on that side, because this is the medial most recurrence, which is the common, and we need to, you see, cover the at least 2 centimeters beyond the midline. Right, and as per the, you see, the myopectineal orifice, the concept, we have to, critical view of myopectineal orifice, we have to go almost 2 centimeters below the pubic bone. So this is the pubic bone here. So this is the direct defect. This is the lateral edge of rectus muscle. This is the inferior epigastric vessel, and this is the inferior epigastric vessel, and we have dissected the pseudo sac. It has gone down. So we have dissected the right-sided Cooper's ligament. We are into the cave of retigius or space of retigius. We have already dissected the space of augurus laterally. We have made adequate space for placement of mesh. Now we have catheterized him, so his bladder is down. So we are just making we should not dip here too much because there are obturator nerve. Since he doesn't have any obturator hernia, so there is no need to you see poke here, and you can see these vessels.
Yes, we can see them
So
clearly.
these are the vessels. You see, this is what we call as a circle of death, right? So this is these are vessels. We should not rub over these vessels. We should apply any tacker, over these areas. And this is, I hope our dissection is almost complete, right? So this is the midline here. So we have gone almost 2 centimeters across to the left side. This is the right Cooper's ligament here. This is the direct defect, and this is the angle of this is the internal ring. You see, testicular vessels and spermatic cord are going. So this is the spermatic cord medially, reflected medially. So we have to make it sure that no.
Professor Atri,
Yes.
Professor Atri,
Yes, sir.
just bear with us because we'll be leaving you for some time.
Right, sir.
Okay?
So
just please bear with us for a few minutes.
I'll be placing a 3D mesh from Medtronics and fixing it with the tacker, and then closing the peritoneal flap here.
We are closing the first session of today.
Right.
Now,
सर अब चेयरपर्सन चेंज हो गया, आपका ऑडियो बंद है अभी, अब ऑडियो 41 का होगा शुरू, ठीक है? हाँ, फिर आपका आ जाएगा.
Department of General Access and General Surgery, kindly come on the podium and felicitate the chairperson.
जी हाँ, मीडियली थोड़ा सा देख लो बस. 3D मैश है ना, ये चेंज करना, ये निकालना पड़ेगा. वो नहीं, ये हाँ, ये वाला, बस ये वाला. ये आपको थोड़ा नीचे आना पड़ेगा बस, बाकी ठीक है, मस्त. ब्लडलेस सर्जरी हो गई. आप पावर टैकर यूज़ करोगे इनका, है ना? बस ओके. ये वाला, हाँ ये.
Professor Iqbal Salim, please. Professor Salim,
कुछ नहीं. उधर टच दे दो थोड़ा किसी को.
Yes, you are.
ऊपर ऊपर.
Altaf Ahmed Malik. Doctor, Abba, please.
बस
I think it's okay.
हाँ, बस एक बार देख लो फ्लैप, यहाँ पे करना पड़ेगा,
Yeah, we can hear you. We can hear you, Sunil.
वो क्लीन करना पड़ेगा सब, वो वाला, यही
Yes, we have seen. What's
ये
your
वेसल
plan?
है ना, थोड़ा सा उतार दो, ये हाँ, ये वाला, हाँ आप फ्लैप देखो ना जो वेसल के ऊपर आ रहा है, बस वही ये वाला, ये हाँ बस आप बढ़िया, यही वाला
So can you
नीचे
hold on for a minute because there is change of cards here. Just a minute.
ये क्लीन करो।
Thank you so much. Now for the next session, we like to call the chairpersons on stage. Professor Nisar Mani sir.
ये
Professor Ajaz Raj sir.
Camera taken.
सीधा सीधा
Sanjeev Singla.
हाँ
Dr. Harvinder Singh Goyal.
टॉर्चो से
And,
ये क्लियर, हाँ ये क्लियर, बढ़िया बढ़िया, यही
ऑडियो खराब है ना उधर, तो हमें दे दो।
नहीं, ऑडियो भी वो ना फिल स्टेशन कर रहे हैं, ऑडियो भी हॉल में है, आपका उनका किसी का भी नहीं है। हाँ, थोड़ा सा क्लीन करो बस, ये हाँ ये वाला फिनिश कर दीजिए, यही है बस। मैश 3D वाली थी ना, राइट साइड, टेक्सटाइल एंड राइट, आप उठा के देखो ना, आप उठा के देखो, हाँ ठीक है ठीक है, शिफ्ट करो ऑडियो से, हमें मैच डालनी है यहाँ पे।
Sir, I hope you can see. Is this okay? So this is the midline. I have completed the dissection. So I'll be using the 3D this
Textile.
textile mesh from Metronics.
Please repeat which mesh you are using, sir?
Metronics textile mesh.
दिखाओ।
Okay, sir. And
So 3D mesh. I'll be using a powered tacker from Merrill.
Right, sir.
I'll be using all the whatever possible. I'll be closing the peritoneal flap with Statafix.
Can we know the reason why you have chosen this mesh?
This is a anatomical mesh where it conforms to the contours of the pelvis, and this is the macroporous mesh, anatomical mesh made for right side and left side both. The just you can see how it spreads. We are using almost 15 into 12 centimeter mesh, so this spreads very nicely, and since it's a macroporous mesh, so we have to go across the midline, at least 2 centimeters across the midline. So that's the medial edge of the mesh. So we have to see again and again that the inferior edge of the mesh has to rest comfortably over the peritoneum, and no part of the peritoneum goes behind the mesh.
It has snugly got fitted.
Yes, so it fits
You need to
into.
use the tackers.
Yes, I am using powered tacker from Merrill. It's it comes in a both absorbable as well as non-absorbable text. Right sir, and then I will be closing the peritoneum with this thing. Give me tacker. You can see this tacker has a definite indication that how many staples are there, how many you have fired, and this is a adapter operated this thing tacker. So again and again I am I am focusing on the inferior margin of the mesh.
For audio visual, please lower the voice. The tone is very high. Please.
Hello.
Volume down. For audio.
So again and again I am watching the inferior margin of the mesh. That's the most important thing. And we had a very tough adhesions with the VAS. Give me tacker please. Move the camera. So this is the tacker from Merrill. It has a marker. It is written 15 here. Can you see it? 15. So as we will go, it is just a powered operated tacker, and as we we have to just press this button and it fires. Let's see how it goes inside. Just see how it goes. So This is, we'll be fixing the, just see, it has, you see, applied. I'll be fixing one more here.
Just about 2 weeks in crisis. बढ़िया सर फंक्शनिंग का दिखाना सर की शक्ल भी लाना या क्या करते हैं यार तुझे वीडियो
So since there was a vessel, I'll more. Since I'm not very sure about, we have to see this tacker. I'll apply one more. Should I?
बढ़िया है सर
Dr. Atri,
Yes, sir.
so two things about the recommendations. A, less tackle in a unilateral groin hernia repair.
Right.
Two, not to the bone anymore.
Right, sir.
Yeah, so two things are important, and you rightly mentioned always look at your inferior flap.
Right.
So I think you're fine, even if you don't fix it. Some people might say it will still remain there.
Since it's a 3D mesh, so I think it should stay there. So now I'll be closing the, you see, flap with the Statafix, so that good morning, sir. Dr. Singla, sir, welcome, sir. I hope you have been taken care of in by the organizing team. Thank you so much, sir. Sir? Yes, we can, you see, there is no need to dissect the sac up to the, you see, fundus in the scrotum. So we can, you see, transect the sac, and that's what we call as a herniotomy or circumcision of the sac. And we can keep the distal sac as such, or we can fix it. If it, yes, sir.
It's not that fixation. We are just discussing that
Right.
a large direct hernia.
Right.
There is a big pseudo sac, not sac.
Right.
So many people do just pull the sac out, invert it, and tack it to the rectus abdominis to reduce the seroma formation. Seroma formation is a
Yes,
very common
yes,
problem.
we can do it. Not only rectus also, we can fix it to the Cooper's ligament also.
So the Coopers we avoid because if you put fix it to the Cooper, then
Right.
mesh fixation will be hampered.
Right.
So fixing it to the rectus abdominis muscle.
Yes,
on
definitely,
the,
definitely.
On the roof will
Yes.
not hinder the mesh, and seroma will be much less. Seroma
Yes,
will-
definitely it helps in reducing the stroma formation, sir. Sir, you are not audible, sir. Please sound. Audio, beta.
Hello.
Hello. Yes, sir. Hello.
Hello.
Hello. Am I audible, sir?
Yes, sir.
What is the question, sir?
How will you manage the seroma?
Sir, I think seromas are better.
Can gain or not?
No, sir. I think that we should wait. There is no need of, you see, aspiration and re-aspiration. You see, we watch these patients, follow these patients for 3 weeks, 6 weeks until they resolve. Most of them they resolve.
Good morning, sir. I am Dr. Kuldeep Dhawan from Chandigarh.
So, good morning, Dr. Dhawan. How are you? Welcome. Welcome to this event.
Very much.
And I hope you have been taken care of by the organizing committee.
Yes, sir. Yes, sir. Very good, sir. Sir, as far as the seromas are concerned, so we can definitely tack the pseudosac over the Cooper's ligament or over the rectus abdominis, but we can give the pressure over the sac side post-operatively with the 2 or 3, you can say, pads, so to prevent it.
Sir, you see, in small hernias, there is no need for giving any pressure. Even you see, we avoid giving pressure even in large hernias. Most of these seromas, they, you see, resolve with time.
We know that. We know that. It is not.
And you see, you see, go prematurely to for aspiration, unnecessarily, there are chances that you may introduce some sort of infection and create a disaster.
We do it under aseptic techniques. Sometimes in private practice, people, they are apprehensive. Patient is always apprehensive. What is this? We have come here for the surgery of the hernia, and the hernia is seen post-operatively. You need to sometime take care of that.
Sir,
we know in private practice and in government practice, there is a lot of difference. You can make the patient understand that it is going to resolve very soon. But in practice, sometimes patient comes from outside, out of India, and he says, okay, no, I need to resolve it right now. So then what we do under aseptic precaution, you aspirate that, or you want to prevent that. If it is a large one, you can give pressure over the hernia place with 2 or 3 pads. If it is a large set.
Sir, since we are into both into government job as well as the practitioners, this is what we have found, that you have to convince the patient that this is your body fluid.
Yes.
So your body will take care of it.
No,
right. And if it doesn't settles down, say 2 months, 3 months, you can possibly take a chance. But there is always a risk under many aseptic conditions. Whatever conditions you do, there is always a chance of mesh getting infected.
Back with you. Can we shift to OT part now? Can you shift to OT part now? Dr. Shah is there. Yes. That section. Yeah, we are at OT one, please. Go ahead. Yes, sir.